Hello, this is Drs. Rohit Gandhi and Emily Conrad, staff emergency physicians from Hôpital Montfort. Due to the precautions required for the novel coronavirus, many sick patients will be placed in negative pressure rooms, which poses significant new challenges in the form of resources, communication, and access to equipment. In collaboration with ED nursing colleagues, we have developed a standardized strategy for protected resuscitations, and this video will serve as a standardized approach that we can all use to reduce errors and improve the flow of communication in high-stress situations.
The first goal is to understand who is involved in each code and what their role is. Typically, we will have 2 physicians, 4 nurses, 2 RTs, and 1 PPE officer. Donning to enter the room will be 1 MD, 1 RT, and 2 RNs.
The lead MD, who will be known as MD1, will lead the resuscitation. Given resource constraints, they may be asked to perform certain tasks such as CPR, applying pads, or the Lucas 3 machine, which is not typical in usual resuscitations.
RT1 will assist with airway management. RN1 will lead the hands-on care of the patient, such as IV, monitors, CPR, and medication administration.
RN2 leads the nursing coordination for the code, one of the more difficult roles. RN2 charts all orders on the whiteboard from MD1, then communicates items required from the outside. RN2 proactively prompts members for missing or not administered items and charts key events. RN3, who will be located in the antechamber, will be the link to the outside. RN3 will prepare any medications for RN2. RN3 will also liaise with RN4 for any missing items located outside of the room.
RN4 acts as the runner, taking orders from RN3 to get items not available in the room or antechamber. Outside the resuscitation room, only the backup MD, known as MD2, backup RT, known as RT2, and PPE officer should be within the dotted black line, designated the resuscitation zone. Any observers should remain outside this zone. The PPE officer shall enforce this.
MD2 will be donned in full airborne precautions outside of the room to serve as a backup for MD1 for airway or other procedures. In order to conserve PPE, one can consider having your N95 in hand instead, applying it only if you are anticipating entering the room. MD2 is also available for discussion on case management with MD1 as needed. RT2 will remain outside the room and help to provide any assistance or equipment required by RT1.
The PPE officer will have the sole job of ensuring each member is donned adequately before entering the room. They will also observe the doffing process. They will not assist with any other nursing duties. As part of preparation, a team huddle should be performed to assign roles, don PPE, and bring basic medications such as the COVID intubation kit into the room.
Each member will be provided with walkie-talkies and name tags to easily identify roles or assess if any roles are missing. Stickers should be placed on protective gowns only. The following 4 members will have walkie-talkies, as this will be important for the flow of communication.
The flow of communication is critical. The following is our suggested approach to communication in protected resuscitations. MD1 will give clear and precise orders directly to RN2 and RN2 only. RN2 will relay the orders to RN3.
At the same time, RN2 will chart the verbal orders on the whiteboard and will continue to include other important items requested other than medications, such as an IO kit. The whiteboard is placed strategically so the resuscitation team and RN3 in the antechamber can visualize it. Each order should have an empty checkbox to allow identification of items not yet in the room or administered. Once the item is received by RN2 from RN3, but not necessarily administered, the letter R will be written beside each item. This communicates to everyone that the item is now available in the room. Once the item or medication is given, RN2 will check the box and note the time it was given. As a pearl, RN1 can help by announcing the time the medication is given, which will prompt RN2 to check it off and offload RN2 from noting the time.
RN3 will then communicate with RN2 that they understand the order for closed-loop communication. If RN3 does not have the item in the antechamber, they will notify RN4 to obtain or to prepare the missing item. Finally, the last line of communication lies with MD2 outside the room. MD2 can communicate with MD1 through RN2 for key pieces of information or advice. We will attempt to limit the chatter on this line. Alternatively, MD1 or RT1 can borrow the walkie-talkie from RN2 to ask for advice or assistance from the outside team. All other irregular communications, such as from ICU or the FS, will go through MD2, who will disseminate this information appropriately.
Here are some pearls based on feedback from previous simulations. 1. Refer to everyone by code names listed on the stickers, i.e. RN4, I need 2 milligrams of Ativan IV. This limits confusion and allows others on the walkie-talkie to understand the flow of communication. 2. Make sure to close the loop, i.e. understood RN3, 2 milligrams Ativan IV coming up. 3. MD1 should make eye contact with RN2 to give orders as much as possible. Speaking loud and clear and confirming the order to close the loop is important even in person, as the masks can significantly impede audible requests.
4. If orders are not written on the whiteboard, they are not considered ordered. MD1 should repeatedly verify that their orders are properly transcribed. 5. RN2 and 3 should be proactive and follow up on medications not yet in the room or not yet given. MD1 and MD2 can also keep an eye on this as well.
Finally, CPR can be a resource-intensive process. PABs trained in donning and doffing are available to provide CPR support. However, the use of a Lucas 3 can also be requested and placed onto the patient by MD1 and RN1.
Don't forget, it is important to debrief as a team as much as possible for continued learning and improvement. Thanks for listening.